Today I will be taking a patient with an excessive lower back arch through the corrective exercise continuum. A lower back arch affects much of the body, but today we will be focusing on the lumbopelvic hip complex, also known as the LPHC region. First, we will assess this patient's static posture. Here he is from the anterior view. You can only see a few imbalances. One is that both feet turn out and flatten, showing overpronation. However, his knees are in line, his hips are stacked and in line with each other, his shoulders are in line with each other, and his head lines up with the rest of the body. Here he is from the lateral view. This is our most important view because it shows truly what we are focusing on, which is the lower back arch. However, starting from the feet up to the knees, he is stacked and shows no imbalances there. The LPHC shows a massive lower back curve to the point where you can hardly see the back behind his arms. Next, the shoulders are slightly rounded and the neck is slightly in extension in order to keep his head stacked. Here he is from the posterior view. This view does not show us much for the low back arch, but it does show something very interesting in the LPHC. Starting at the feet, both feet are turned out to the point where you can see every toe except the big toe. His knees show they are stacked, but when you look at the LPHC, you can see the left PSIS is lower than the right PSIS. This would indicate some imbalances from left to right. Possibly the muscle on the right are being more affected by the lower back arch than the ones on the left. The other kinetic checkpoints show no imbalances. Next, we will view his impairment while moving, specifically doing an overhead squat. An overhead squat assessment has the patient squat down while holding their arms next to their head. The best way to cue for this exercise is to tell them to hold their arms next to their ears and pretend as if they were sitting in a chair. You do not want to give too much information because you want to see their imbalances. Here is the anterior view of the patient's squat. It is important to watch the feet, knees, LPHC, shoulder, and cervical regions to make sure he's doing this correctly. You can see that his feet are very externally rotated. His right knee shows some varus while squatting, indicating some imbalances throughout that leg. However, the rest of his body from this view is good. He does not show any imbalances from the front in the LPHC, shoulders, or cervical regions. Here is the lateral view of the patient's overhead squat. This is the most important view for the LPHC to see the lower back arch in the patient. His feet look fine from the lateral side. There is no overpronation or supination. His knees show no sign of imbalance. As you can see though, his LPHC maintains the lower back arch throughout the whole squat. However, his shoulders are stacked as well as his cervical region, and he does not struggle with keeping his arms next to his ears when he squats, telling me it is not a latissimus dorsi tightness that is causing his lower back arch. From the posterior view, we see again his massively externally rotated feet, and his left foot drops in, showing that he has excessive overpronation. His knees shake a little, but they do not show massive varus or valgus. His LPHC does not show any sort of hip hike, but those landmarks for the right and left PSIS are still uneven with each other. His shoulders and scapula look fine, other than the fact that it is noticeable he is shrugging when performing the squat, suggesting tightness in the upper traps or the levator scapula. Finally, his cervical region is stacked with the alignment of his body. The next assessment I will do on the patient is the range of motion assessment. This will help to tell me if any muscles are overactive and not allowing for full range of motion. In a lower back arch, possible overactive muscles that would affect range of motion are the hip flexor complex, the erector spinae, and the latissimus dorsi. Therefore, I must test the patient's range of motion at the opposite of what the overactive muscle actions are. So I will test hip extension, shoulder flexion, and internal rotation. For the hip extension test, I will line up the goniometer with the axis at the greater trochanter. The stationary arm will be at the lateral midline of the trunk, and the movement arm will be aligned at the lateral midline of the femur, referencing the lateral condyle. This patient's range of motion measurement was 10 degrees on the left side and 1 degree on the right side. The norm for this range of motion is 10 degrees. Therefore, he has limited range of motion and hip extension on his right side. For the shoulder flexion test, I will line up the goniometer with the axis at the lateral shoulder, 1 inch distal to the acromion process. The stationary arm with the mid-axillary line of the upper thorax, and the movement arm with the lateral midline of the humerus, referencing the lateral epicondyle of the humerus. This patient's range of motion measurement was 45 for the left and 45 degrees for the right. The norm for this range of motion is 45 degrees of flexion. This tells me that his latissimus dorsi are not the reason for his lower back arch. For the hip internal rotation test, I will line the goniometer up with the axis over the anterior aspect of the patella. The stationary arm will be perpendicular to the ground, and the movement arm will be aligned with the anterior midline of the lower leg, referencing the tibial tuberosity. The patient's range of motion measurement on the right leg was 35 degrees, and the left leg was 45 degrees. The norm for this range of motion is 45 degrees. This keeps with the recurring theme that his right side has an imbalance that would cause a lower back arch because of his lower range of motion. The next assessment I will do on this patient is the manual muscle test assessment. The manual muscle test will help to tell me if any muscles are underactive which would cause the impairment. The manual muscle test scores the patient on a scale from 1 to 3, 1 being weak, 2 being compensating, and 3 being normal. When dealing with a low back arch, some possibly underactive muscles would be gluteus maximus, the hamstrings, and the core stabilizers. First, I will manual muscle test the gluteus maximus, with the patient lying prone and extending at the hip with their knee flexed. Then I will resist downward into hip flexion. The patient's evaluation is a 3 on both the left and right sides. Next, I will be assessing the strength of the biceps femoris. Having the patient lay supine, flexed at the knee and at the hip, I will have him press down into my hand with his heel while I resist in an upward fashion. The patient's evaluation is a 2 on the right with little weakness and compensations performed, and a 3 on the left. This hints to the hamstrings being an underactive muscle group causing the low back arch. The next assessment I will do on the patient is the rectus abdominis muscle test. This will give me a general idea as to how strong the core stabilizers are. First, the patient will crunch slightly to engage the rectus abdominis, and I will put pressure on his shoulders, attempting to push him out of trunk flexion. This patient scored a 3 on his core stabilizers manual muscle test. Based on all of the assessments, this patient is showing only to be affected on his right side. His right hip flexor complex is tight, not allowing for full hip extension, and his right biceps femoris scored a 2 on the manual muscle test, telling me he is underactive in the hamstrings complex and overactive in the hip flexor complex. Therefore, I would take this patient through the corrective exercise continuum that follows: inhibit, lengthen, activate, and finally integrate. Corrective exercise continuum step 1, inhibit. For the inhibiting phase, I want the client to SMR his overactive muscles. This allows for him to turn off the overactive muscle in order to work on it to get it back to normal length. In the video, it shows him rolling out his hip flexor complex. In the case of a lower back arch, the possibly overactive muscles that you can inhibit are the hip flexor complex and the latissimus dorsi. Therefore, the patient rolled out his hip flexor complex starting in the mid-thigh and rolling all the way up past the iliac crest of the pelvis, making sure to pause on any tender areas. Corrective exercise continuum step 2, lengthen. After the overactive muscle has been inhibited or turned off, it is shorter than its optimal length because it has been contracting constantly. Therefore, the patient needs to lengthen the once overactive muscle to get them back to optimal length. Here the patient statically stretches his hip flexor. He is on his right knee and raises his right hand above his head and then laterally flexes to the left until he feels a stretch in his affected right hip flexor complex. He will do this stretch 3 times, holding the position for 30 seconds. He would also stretch his latissimus dorsi and his erector spinae since they also need to be lengthened. Corrective exercise continuum step 3, activate. Once the overactive muscles have been inhibited and lengthened, the other aspect of the imbalance are the underactive muscles. Therefore, we turn on or activate the underactive muscles that would be causing a low back arch, which are the glute max and the abdominal complex. I chose to give the patient an isolated strengthening exercise since he is not a weak patient. Here he is doing a bridge on an exercise ball. Since his glutes did not show any signs of weaknesses or being underactive, but his hamstrings did, I made him lay with the top of his shoulders and neck on the ball and his feet on the ground. Then he needs to thrust his pelvis into the air until his body from his knees to his head is in a straight line. This helps to activate both the glute max and his hamstrings. He needs to do these bridges 10 times for 3 sets. Another exercise he could do is planks in order to activate his abdominal complex. Corrective exercise continuum step 4, integrate. The last phase of the continuum is to integrate all of the muscles to ensure they are in proper balance now. The integrate exercise I chose for this patient targets the whole body. The ball squat to an overhead press. The patient has dumbbells in each hand, not too heavy but enough to work the latissimus dorsi. Then press up against the wall with a ball at their back. They will squat down, rolling on the ball, and then when they stand up they must press the dumbbells into the air above their head. This allows for the patient to work their hamstrings and hip flexors in the squat phase, their core stabilizers by maintaining the ball against the wall, and finally strengthen their latissimus dorsi with the overhead press, covering all the muscles that have been worked on in the first 3 phases of the continuum. The patient will do 3 sets of 10 reps, making sure they stay controlled on each rep. And that is how I would assess and correct the low back arch impairment. Thank you for watching.